My sincere thanks and best wishes to the organizers. My presentation is simplifying the pediatric laparoscopy using the stab incision for instrument access. So here we have kind of done a study between two groups, aiming to prove that stab incision is a simple way of introducing the instruments into the abdomen for the laparoscopic procedures. We have compared this study with cases of laparoscopy with conventional cannula system. So the stab incisions offer measurable benefits over the cannula system. So the study will compare the procedural metrics, patient recovery profiles, complication rates between the two groups. We identify the significant clinical advantages that justify the use of stab incisions for instrument introduction over the conventional cannula system. Here, this is a small video. It's not playing, but the procedure is very simple. We give a small incision with a 11 blade into the peritoneal cavity, and we'll introduce a 3 mm instrument over the incision without dilating the tract with the artery forceps. So there are several case studies published before. This is published in 2004, demonstrating the usages and the advantages of stab incisions for instrument access in laparoscopic urological procedures. This was done in 2003 in pediatric surgery procedures. Several people have performed this stab incision technique and demonstrated the advantages. So on the first slide shows the babies with conventional cannula system, and the second picture shows the babies with the conventional, stab incision procedure. So this is a prospective study, comparative study done over 18 months. The first 30 cases were selected for laparoscopic herniorrhectomy using trocars. The next 30 patients were selected for the stab incision method. In both the procedures, we have used a 5 mm 30-degree camera using a 5 mm cannula in the umbilicus. And we measure the variables such as operative time, analgesia, cosmesis, etc. So these are the results. In the stab incision group, we have particularly noted that the time taken for the completion of procedure is much less compared to the conventional method. Otherwise, the pain, the recovery from the surgery, from the discharge from the day of admission, those are all more or less comparable in both the groups. The complications that are noted in both the groups are very minimal, scrotal edema, peritoneal bleed, and things like that. The cosmesis is also comparable between both these groups. The pain in analgesic requirement is marginally different between the conventional cannula group as well as the stab incision group, which is not much to expose. So we see many trocar-related complications while using the trocars, such as misfits between the trocar and the instrument we introduce. There may be small washer cracks through which the gas insufflation may not be so much sufficient. The instrument may fail to go through a particular company cannula. So these are the differences, these are the difficulties we have noted while using the conventional cannula system with the instrumentation. Sometimes the trocar as well as the instrument, these are so heavy compared to the baby's abdomen, they may tend to hang out of the abdominal site. These are the problems we have realized while operating with the trocars. This is not applicable in all the cases. Definitely, the stab incision system is not applicable for bigger children, those with fatty abdominal walls, in the areas such as suprapubic area or axillary area. But it can be definitely done in newborns while performing the laparoscopy or thoracoscopy. Definitely, it can be used in VATS and children with thin abdominal wall and those with under 20 kilograms weight. Stab incision with instrument access can be easily done. So these are techniques which helps in precise placements of the incision, direct instrument entry into the peritoneal cavity, and adapting the stab incisions and triangularization according to the location of the surgery. Numerous benefits are there. But one important benefit over the trocar system is that the time taken to fix the trocar to the abdominal wall is saved while doing the stab incision system. We observed few minor complications such as surgical emphysema and false strike reaction, and inability to connect to the gas insufflation cannula in stab incision system, whereas gas insufflation can be used through the umbilical cannula. We have performed this technique in other surgeries, major surgeries also. Here we performing the thoracoscopic diaphragmatic hernia repair using the system I have mentioned. Both the intra and extracorporeal suturing is possible with this. Pyloromyotomy regularly we do, and many others also do the pyloromyotomy with the stab incision. Also performed laparoscopic anorectal pull-through using the simple stab incision technique to introduce the instruments. Diurnal atresia, definitely we are doing. Here, this is a typical case of diurnal atresia with situs inversus, which we have done with the simple system. Laparoscopic oviductocyst excision along with the excision in the hypodegoid urinostomy has been also been done. So concluding, this is a simple technique for enhanced outcomes in the pediatric patients, versatile and effective technique, and it's the future of pediatric laparoscopy and must be tried in many other surgeries also can be tried in many surgeries. Thank you.
Thank you, Dr. Srinivas.
Yes.
Just one question that toward the end of the procedure, though it's cosmetically much better than introducing a trocar and then putting instrument. Towards the end of the procedure, sometimes gas leak happens. So what is your technique for preventing?
Gas leak will not happen because your incision and the instrument, you should not dilate the track after you incise the 11 number blade. Incise and simply introduce the incision. The video is not playing, so I would have demonstrated it.
Okay, any question? Yes.
We initially thought gas leakage will be the problem, but it has not come.
So my concern is about operations where we're having frequent instrument changes.
It can be done. It can be done.
It's not whether it can be done. So is that going to be a problem in these situations?
It won't be a problem. It won't be a problem. The incision is hardly 3 millimeters. In thin abdominal walls, the tissue will approximate as soon as you remove the instrument and reintroduce. Okay. We have not observed any surgical emphysema or things like that.
No, I'm saying will we find that same track again? Because sometimes we don't, particularly when the gas is released from the abdomen and the tissues slide on each other. So you end up making multiple entry points.
That's what we anticipated, but we have introduced suction cannulas and dissectors and the needle holders through the same incision without much gas leak, without losing the pneumoperitoneum.
Yeah, I think it's very attractive, particularly for introducing a needle.
Yes.
Because the needle will slide in even through a 3 millimeter instrument.
It is very easy to introduce the needle and retrieve the needle.
Yeah.
The thing is, you cannot retrieve a specimen through the small incision.
Okay, thank you.
Okay. So we go on to next talk.
Thank you all.
Thank you, Dr. Srinivas.